Under motor examination, the first one is the attitude of the limb, that is the position of the patient or the affected limb. Muscle wasting in the upper limb is determined by the circumference 10 cm above and 10 cm below the olecranon process. In the lower limb, circumference 16 cm above the patella and 10 cm below the tibial tuberosity. Tone of the muscles is the resistance offered by normal muscles to passive movement. Anti-gravity muscles in the upper limb are the flexors and in the lower limb are the extensors. Tone of the muscles can either be hypotonic or hypertonic. Hypotonia is wherein you see flabby muscles which offer less resistance to passive movements. Hypertonia is where there is increased resistance to passive movements. Cause of hypotonia is lower motor neuron disorders or cerebellar lesions. Cause of hypertonia is seen in tetanus, pyramidal lesions and extrapyramidal lesions. Hypertonia is further divided into spasticity and rigidity. Under spasticity we have clasp knife spasticity, and under rigidity we have lead pipe rigidity and the cogwheel rigidity. Differences between spasticity and rigidity. Spasticity is seen in case of pyramidal lesions, whereas rigidity is seen in case of extrapyramidal lesions. Spasticity affects only one group of muscles, that is the anti-gravity muscles. For example, the flexors in the upper limb and the extensors in the lower limb. Whereas rigidity affects both the group of muscles, that is flexors as well as the extensors. In case of spasticity, the resistance is seen at the beginning and at the end range of motion, and it is velocity dependent. Example of spasticity is clasp knife spasticity, where the resistance is felt at the beginning and the end range of motion. Example of rigidity, we have cogwheel rigidity and the lead pipe rigidity. In cogwheel rigidity, the resistance is not throughout but jerky movements are present. In lead pipe rigidity, the resistance is present throughout. Grades of tone. Grade 0 is no response flaccid. Grade 1 plus decreased response hypotonia. Grade 2 plus normal response. Grade 3 plus exaggerated response. Grade 4 plus sustained response or hypertonia. Method to check the patient's tone. The patient should be distracted, that is, you can talk to the patient while assessing the tone. 10 repetitions should be done quickly because tone is velocity dependent. The outcome measure used in case of increased tone is modified Ashworth scale. Let's see the modified Ashworth scale. Grade 0 is no increase in tone. Grade 1, slight increase in tone manifested by a catch or release or by minimum resistance at the end range of motion when the affected part is moved in flexion or extension. Grade 1 plus is slight increase in tone manifested by a catch or a release or by minimum resistance in the remainder range of motion. Grade 2 is marked increase in the muscle tone but the affected part is moved easily. Grade 3 is considerable increase in the passive range of motion and passive movement is difficult. Grade 4 is wherein the affected part is rigid, that is, there is increased tone in both the group of muscles, that is flexors and extensors. Then we have power. According to the MRC grading of power, grade 0 is no power or no movement at all. Grade 1 is flicker of contraction is seen. Grade 2, movement is possible with gravity eliminated position. Grade 3, movement is possible against gravity. Grade 4, movement is possible against minimum resistance. Grade 5, movement is possible against maximum resistance. This is considered as normal power. Let's see the pronator drift test. The patient holds the arms outstretched with the hands supinated for about 15 to 30 seconds. The eyes are closed to avoid visual compensation. The weak arm gradually pronates and drifts downwards. This indicates pyramidal tract weakness. That is, the motor neurons controlling the voluntary muscle movement in the hemisphere opposite to the affected or the weak limb are affected, which is seen in UMN lesion. Then we have range of motion or ROM. Let's see the shoulder ROM. Shoulder flexion 0 to 180 degree, shoulder extension 0 to 60 degree, shoulder abduction 0 to 180 degree, medial rotation 0 to 70 degree, lateral rotation 0 to 90 degree. Wrist flexion 0 to 80 degree, wrist extension 0 to 70 degree, radial deviation 0 to 20 degree, ulnar deviation 0 to 30 degree. Elbow flexion 0 to 135 or to 145 degree, elbow extension 135 or up to 145 to 0 degree. Forearm pronation 0 to 80 or to 90 degree, forearm supination 0 to 90 degree. Ankle plantar flexion 0 to 45 or up to 55 degree, ankle dorsiflexion 0 to 15 or up to 20 degree. Foot inversion 0 to 30 or up to 35 degree, foot eversion 0 to 15 or up to 20 degree. Hip flexion 0 to 120 degree, hip extension 0 to 30 degree, hip abduction 0 to 45 degree, hip adduction 0 to 25 or up to 35 degree, hip medial rotation 0 to 45 degree, hip lateral rotation 0 to 45 degree. Knee flexion 0 to 130 or up to 140 degree, knee extension 130 or up to 140 degree to 0 degree. In the cervical spine, cervical flexion 0 to 40 or up to 50 degree, cervical extension 0 to 50 degree, cervical side flexion 0 to 45 degree, cervical rotation 0 to 90 degree. In the temporomandibular joint, protrusion 0 to 3 or up to 10 mm, deviation 0 to 10 or up to 12 mm, depression 0 to 35 or up to 40 mm. Now let's see a few special tests. The first one is the head drop test. The patient is in a supine lying position and holds the head off the bed. Normally the head drops to a certain extent. In case of hypotonia, which is low tone, the head drops completely. In case of rigidity, which is in case of increased tone, the head stays in one position. The pendulum test. The patient sits at the edge of the table or the couch. The therapist passively extends the knee and then releases it so that it swings freely. In case of flaccidity, the leg moves down rapidly. Spasticity, the leg moves down slowly and the amount of swing is decreased. In case of rigidity, the leg doesn't move down at all. Then we have the arm drop test, wherein the therapist abducts the patient's arm or the shoulder to 90 degree. Along with that, perform external rotation. Ask the patient to slowly lower the arm at the side. If the patient is not able to hold the arm and returns the arm down immediately, this is seen in case of rotator cuff tear.